Hello, everybody. My name is Dr. Vera Tarman, and I am an addiction physician working out of Toronto, Canada. So welcome, and I hope you find something useful. So all in all, what I can say is that if you don't like the word addiction, I think it would be totally accurate to say that not, hey, I'm an addict, but I have a dopamine impairment syndrome or a dopamine deficiency syndrome. I think dopamine impairment works well because something's happened to the dopamine that should be 1 to 200, and if you're in that 4 to 600 and you've blasted out these receptors and they've, all of this change has happened, that's an impairment syndrome. That's a physiological dopamine impairment syndrome. You can use that word for if you don't like the word addiction. So let me say a couple of more interesting things about dopamine. I've talked about dopamine as the sort of engine or mechanism behind addiction. By the way, it's not just dopamine. There's serotonin, endorphin as well. There's GABA as well. But if you understand the dopamine story, you've got a really nice handle on the sort of dynamic of addiction. Okay, but the dopamine does more than just the addiction profile that I've explained. It also has a role in movement. And I'm going to tell you this stuff because we see this kind of thing happening with in the addiction world as well. So movement, when you're in the higher realms of dopamine, people will start to have unusual movement. So let's just leave the addiction world aside and let's just talk about excessive dopamine. So if we think of excessive dopamine, where do we see that in I don't want to say normal nature, but in non-addictive environments? A person who has Tourette's. A person who has Tourette's has unusual twitches. They have unusual movements. Really, it's not actually the movement that's the problem. It's the urge to move. That's the problem. It's that urge. It's that want. It's that, I gotta scratch that itch, which is what dopamine is for drug. And in this case, for a person with Tourette's, it's to move. I just got to get this thing. And so they do that. And we often think, well, Tourette's is the movement. It's actually the urge to move or swear or whatever manifestation it takes in that person is excessive dopamine. Another place where we see excessive dopamine is Huntington's chorea, which is a condition very rare, almost, I think, exclusively genetic, where a person moves and they can't stop their movement. And it's something in the brain where there's an excessive dopamine keeping the movement going. And so that's excessive dopamine. Now, in the drug world, we will see people who are using, especially the stimulants, which really boost up the dopamine. I mean, alcohol boosts up the dopamine, but not as high. The thing about alcohol is it boosts up dopamine and serotonin and GABA and endorphin. It does a lot, but not so much all at once. It's still above the 200, but it kind of covers a lot of ground, not as high. But cocaine and crystal meth, they're like silos of dopamine, and so you get that movement. So you'll see with a lot of people with cocaine, crack disorder, crystal meth, have twitchy, funny movements. That's the dopamine, and it's often a visual of potentially what's happening in their brain with that. It's like there's sparks of dopamine in various places where there's not supposed to be, and that's the dopamine. The alternative, people who are using drugs in this 1,000 category, when you're in that category and you've got that abnormal movement and all the addiction piece that I've just described earlier, eventually those receptors will become impaired. I mean, it's just think that you're supposed to have a steady pulse like this, and you go bam, 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 bam like this with dopamine crashing. You're just mushing up those receptors, and so that essentially your dopamine is getting squashed. You may have 1,000 out there, but you can't use it anymore. And so now you're going into a dopamine deficit, even in the context of drug use. And so what we can have is actually a dopamine deficiency, not of mood, which is depression, but of movement. And where do we see dopamine insufficiency in the world, not in addiction, but in the mental health world? Parkinson's is a great example. So Parkinson's is where there's a deficiency of dopamine. It's for a different part of the brain, but it's movement related. The substantia nigra, this is a part of the brain that produces dopamine for movement, is for some reason maybe it's autoimmune. We don't know what it is, but for some reason it's not working. It's not creating the dopamine that's required for movement. And so the person becomes very slow and sluggish, and they'll have a tremor, but for the most part, they're moving very slowly and they're often very depressed. And the only way that best treatment for that is dopamine. We actually have a drug called L-Dopa that we give people in that context because there is insufficient dopamine. Now, for these people who are using drugs and they've squashed their own receptors, you can't give them dopamine because that's what you were doing with the drugs, and it's essentially blasted those receptors. So they have what we call a Parkinsonian syndrome. It's not Parkinson's. It's a syndrome. It's a condition that looks like Parkinson's, but it's not Parkinson's. So I can't use the treatment for Parkinson's. I don't know what I can do for this person, other than hope that if you that the receptors will repair themselves. But so if you see somebody that has this twitching movement and also a kind of a slowed, shuffled response, that could be the Parkinsonian syndrome that's developing. Where we often see that Parkinsonian syndrome is when that person who's using crystal meth or cocaine is having their psychotic episode. And so now let me talk about dopamine and psychosis, because this is also very common in the addiction world. Like I said, the movement disorder, and now the second piece, which is the psychosis. And again, where do we see in the mental health world an excess of dopamine that leads to psychosis? Schizophrenia. This is not drug related. This is just, we don't know what causes schizophrenia either. Is it genetic? Is it environmental? Is it a virus? We still don't know, but we do know that there's something about an excess of dopamine that causes hallucinations. Hear things that aren't there, see things that aren't there, believe things that are just simply not true. And which we call delusions or illusions. And we see that with excess of dopamine. We also see that with the excess of dopamine with people who use drugs. And there is no question in my mind that a person who's, especially a crack smoker, somebody who's been smoking cocaine excessively, is going to develop a cocaine psychosis, drug-induced psychosis. When I am interviewing a person that has an issue with crystal meth, I don't even need to ask if they've had a history of drug-induced psychosis. I already know that they have. It just comes with the territory eventually. It's the rare person, the outlier, who doesn't have that experience, because excess of dopamine causes that. So where do we see Parkinsonian syndrome? Maybe in long-term use, yes, but sooner than that, usually a person who has psychosis ends up in the emergency, and with a psychiatrist. And if the psychiatrist is smart enough, and usually they are when they're in an urban center, because they know to ask these questions, they'll ask, what's your history of crystal meth, cocaine, even marijuana, because we're seeing it now with the newer hybrids of marijuana. This stuff causes psychosis as well. It's not a benign drug anymore. Please, I'll talk about marijuana at another time, because it's really worth spending some time talking about it. So anyway, we've got the psychosis. What do? We give them an antipsychotic. And an antipsychotic, that's typically something like Seroquel, Abilify, quetiapine. I'm just giving you the brand names as well as the generic names. Zyprexa, olanzapine. All of these drugs here are antipsychotics, and what they do is they are anti-dopamine drugs essentially, and so they help potentially the movement disorder, and they help certainly the psychosis, which is because of too much dopamine. Maybe they'll help some of the cravings too, which is why we use these drugs a lot in the addiction medical pharmacology. But the danger is, if you have to use too high a dose, you can cause what's called Parkinsonian syndrome. And the first generation of antipsychotics like Haldol or Haloperidol, chlorpromazine, these were like the drugs that were like the first generation in the 1970s and 80s. definitely caused Parkinsonian syndrome because they were much more potent. We used much higher doses. We didn't really know at that time. We weren't able to be as specific as now. So people would have that kind of shuffle and that tremor and the depression and all of that stuff. So these are when you're in the field of addiction, you know, trying to manage the dopamine, the excess, and the surplus and the deficiency, it becomes essentially an art, or if you're thinking about it from a doctor's point of view. But anyway, it's not a simple thing, and dopamine has a lot of roles and can do a lot of interesting, potentially not so interesting things.